Good morning. Good morning. I'm George Johnson. I'm your MC for today. We have an interesting subject, a subject that you guys don't like to talk about. It's called sex. And
How do you spell that?
someone dysfunctional, I'm just going to call it sexual health. And I want you to feel free to ask any question on any subject, and our speaker is equipped to handle that. I remember when I first met him a few years back, and he was known as that bright young urologist. and you know, the word bright and young go together. You ever hear of a bright old urologist? No. But we got a bright group of old men here, don't we? So feel free to ask your questions, because this is an important subject to you. And we want to thank SBP for allowing us to use this room. Please try to keep it clean, because the crew came in last night and cleaned it. And if you other facilities, we have it down the hall. And quite a bit down the hall there for the other facilities that I know some of you will need during the hour. And here's the guys that make this thing work. We need volunteers. If you want to help us out, let us know. Talk to me or Gene at the end of the meeting, and we'll help you get up to speed on this. We're getting on in years, so we need some fresh blood here. And now, did you get your newcomer package? And fill out the first page. Is it still yellow?
No, it's white.
It's white, all right. Fill it out, and the purpose of that is to get to know you. Gene will give you a call, so if you've got any questions, any special needs you may have, we can help you out on that. Okay, we're a support group. We're a special group of patients. We're not affiliated with any hospital or institution. We're independent. And our theme is to help you manage your own case. You have to be your own case manager. Your doctor is not your case manager. He has 3,000 or more patients. You're the one that has to keep a copy of your lab reports. Ask for them. Put them in a notebook. Schedule your PSA frequently, and so forth. So, but we're not a substitute for your doctor, nor what today's speaker says is a substitute for your doctor. What we hope to do is provide you questions to ask your doctor. Frequently, I ask my doctors, what about such and such? Oh, yeah, we could do that. He forgets to think of other things, so remind him. I've also had a doctor say, where are you getting these questions? As if I couldn't come up with them myself. Well, they come from this meeting. And so we hope we're giving you questions to ask your doctor. Our support group got a website. We have a library of very good books, some bestsellers. We got technical notes and things like that. We have a newsletter about new research, rundowns on the previous talk, and who's coming up next. We have an outreach program. If you have a Rotary or another group you think it would be good to have somebody come in and talk about prostate cancer, Gene and I are available. We have a snappy 20-minute or more talk on prostate cancer. We'll be happy to do that. And you are also part of our outreach. The buddies you got are the same age, and they need to get a PSA, remind them. If you have sons, the likelihood of them having prostate cancer is above average, so remind your sons to get a PSA. Monthly meetings, you're aware of those. And next month, We got Dr. Galis coming in. He's an expert on active surveillance, and he's also has some material and information on genetic aspects of prostate cancer treatment too. So that'll be a good talk. So you'll learn a lot. And now, we're going to do a little rundown for our speaker and for newcomers, a little profile of our group. All right, how many are here for the first time? Please raise your hand. Okay, welcome. Come join us, come back next month. I think you will become informed. That's the aim of our group, informed. Okay, how many have been recently diagnosed in the last few weeks or so? Okay, well, you're in the right place. How many have had prostate cancer for up to 1 year? All right, up to 4 years. Okay, 5 to 10 years. See, that's kind of our peak there. 11 to 15. More than 15. Okay, I got 21, and somebody's beating me here.
26.
26. How old are you? How old are you?
84.
84. I'm 86. Anybody get older than 86?
Nobody.
See, I'm still bright though, right? Okay. For you newcomers, you got a long life ahead of you here. Okay, let's do a treatment survey. How many have not had treatment but are on active surveillance? Raise your hand. Good for you. Good for you. That's a growing content, and I hope to see you next month. Surgery. How many had prostate surgery of all kinds? Yes. It used to be the gold standard. How many have had radiation? That's the new gold standard, yeah. Now you see Gene's hand has stayed up. He's had everything. And so is Chuck. And okay, how many are on ADT, hormone therapy? Look at that. Okay, when we talk about ADT, how many have a concern or interest in ED? Raise your hand. Same group? Okay, chemotherapy. How many are on chemotherapy or have had it? 1, 2, 3. Okay. New treatments. Provence, Zytiga, apalutamide. All right. Sir, what are you on? What's new? All right. And, okay.
Provenge, Zofigo, Keytruda, Ron, Casodex, soon to be a brand new one called Olaparib. I'm currently on Xtandi and Zytiga.
Okay.
So, you name it, I got it.
Okay.
Except chemo.
What do you got there, sir?
Lutetium 177 PSM.
All right, everybody is the nose. See Larry here. Okay. If you got the front page, bring it up here after the meeting and I'll take care of it. Okay, how many have recurrence? It's come back. Me, yeah. That's what this program is about. It does come back. There's no real for sure cure. How many are undecided what to do next? I'm in that category too. Okay, so hopefully we'll learn something today that will let us think about that. Okay, guess what? Time to raise some money. We need your financial support. We're going to pass the basket. Just shoot them down the rows here, and appreciate what you can donate. It goes to a good cause. It doesn't go to us guys. It's tax deductible. We're a 501c3. We're not affiliated with any medical or religious group. Keep those baskets going. And while those baskets are moving around, here are the 6 principles that we strongly recommend. 1, early detection and frequent PSA tests. Do you want too late detection? Better to have early. High definition diagnostics, like multiparametric MRI. And if you've done that, then get a targeted biopsy. Have the doctor aim that needle at the lesions or tumor. Much better than getting a random biopsy. Then you're going to know your Gleason score. If you got a 6, hey, you're an active candidate for active surveillance. If it's above that, now you've got some decisions to make. If it's 6, you can do active surveillance. If it's above that, now you got treatment options. And what we recommend is get a second opinion. You want to look at options in the plural. Now, today, we have a gentleman that okay, we're all here. This is a special person. He's a leader in men's health, which really means men's sexual health. He has there's a brochure out there. I recommend you look at it. There's some quizzes in here that I think you ought to take and give it thought to. It's very informative. And so grab a copy on your way out. Life After Prostate Cancer is the title of it. And he's very knowledgeable in the subject. I didn't realize it, but we have a lot in common. He was a graduate at University of Vermont, Veris Montes. I went to the university there. I was not a student. I lived there. I was on base housing there. So wonderful Lake Champlain. And then he went for his residency and internship at George Washington University. I went there too, but not as a student. My office was across the street. I used to go over to the hospital to eat. Pretty good food. See the connection we got. Eh? And then he got his fellowship in Texas at Baylor Medical College in Houston. And I happen to be blessed with 4 years of Texas history in elementary school. And maybe we can get together and talk about that.
At the same time.
Yeah. But he's a very knowledgeable person, and he's still bright and young looking, but he has a tremendous amount of experience. Come on up, Mike.
All right. Thank you for having me. All right. I will. Well, I want to thank you guys for having me back. I've been at UCSD for about 7 years now. And this is one of the first community talks that I've given since I joined UCSD 7 years ago. And since then, I've been doing a lot of these outreach events, speaking to cancer survivors, and you guys are still the most informed group. I remember I got a lot of tough questions on my first talk 7 years ago, but I expect more today. So feel free to stop me at any time. And this is not meant to be me reading slides to you guys, so we can talk. This is meant to be a conversation. And as they mentioned, I am now we just opened our men's health center. It's down the street from here. So that's where we see most of our patients, both cancer survivors and non-cancer survivors. So and there will be some informations if you guys have questions. Sometimes it's a little bit embarrassing. This is very personal, so if you have questions, I'm happy to stay after the talk to talk to you one-on-one as well. So as many of you know, there's goals of cancer treatment, and that these are some of the stuff that as your doctor, we think about when we're prescribing treatment or thinking about treatment for cancer patients. Obviously, safety. We don't want to make you worse off than what you started with, so safety is very important. And then the next thing is cancer control. You know, the goal is to get rid of the cancer, whether it's through radiation, whether it's through surgery, through chemo. The goal is to get rid of the cancer safely. And we also want to minimize side effects. And as we advance in our treatment for cancer, people are living longer, like many of you who's been diagnosed 20-some years ago. So back in the day, we used to say, well, you know, you're lucky that you're still alive. But today, our priority has changed. People's quality of life is really a consideration for everybody. So just because we can keep you alive, but if you're worse off than what you started with, I'm not sure many of you will choose the same treatment. And a lot of times people see me, they would tell me things like, you know, if I knew this is what it was going to be like, I probably wouldn't even want to have it treated. So that's something now that we're having more discussion with patients and helping you all choose what the right thing is. But specifically with prostate cancer, you probably heard of everybody want to brag about their rate of trifecta. What are the trifecta? Number one is cancer control, whether it's surgery, radiation, chemo. The second thing is we want to make sure you're not wearing a diaper for the rest of your life. We want to preserve your urinary continence. And the third part is preserving your sexual function. And this is the priority every prostate cancer doctor are trying to do for you. And we're not going to compromise one for the other. And when all three things are achieved, we call it the trifecta. And that's what doctors brag about at our meetings and say, you know, what's your percentage of rates you can help people to achieve all these things. But what are some of the sexual side effects of cancer treatment? ED. You know, even if you don't have cancer treatment, as we get older, we need help with our erections. So, but definitely after cancer treatment, whether you choose surgery, whether you choose radiation, whether you choose hormone or chemo, there are sexual side effects. Bless you. And second thing is ejaculation problems. As many of you know, once you have treatment on the prostate, it can affect your ejaculation, not just your erection. Not uncommon, people start getting scar tissue build up, and then they complain that, you know, I'm not as big as I'm 18 years old anymore, or they start having curvatures and deformities. And people can also have issues with orgasmic function. Some people don't leak normally, except when they're trying to have sex, and that's called climacturia, and that's one of those things that it's very, very common, actually. And the last thing is that people can have hormonal imbalance or decreased sexual desire or libido, and that's more common in people who receive androgen deprivation therapy, where we chemically castrate you with medications. But a lot of guys, even we take you off the medicine, your hormones do not bounce back. So we give you an expected period of time for your hormone to come back. But if it doesn't come back, part of my job is to help you restore the hormonal balance that we'll go over a little bit later. Let's see. So what is ED? This is what they teach us in medical school. Basically, it's the medical textbook says it's the inability to obtain or to achieve an erection sufficient for sexual activity. And there's multiple causes, but we now know that it's an important part of our quality of life. It's an important part of how we view ourselves as men. It's an important part for our relationship with our partner. So we don't ignore it anymore. So how common is it? As I mentioned, even if you did not have cancer, 1 in 5 guys in America have erection problems. That's over 30 million American men. Back in the day, we used to say that it's all in your mind. You know, if you have erection problems, go see a shrink, okay? But in today's world, we know that 90% of the time, there's a physical reason, and only 10% of the time is psychological, okay? It's not uncommon, people have both, okay? So what is supposed to happen? So this is kind of a picture of what your penis looks like, internally. So when things are flaccid, things are just hanging out like it's supposed to be. During erection, the arteries in the middle brings the blood flow to the penis, and these spaces called the corporal body starting to swell. And once the blood fills these space, it becomes hard. And then for you to maintain erection, the veins on the side of the penis gets pinched off. That's how you maintain erection. And this is what is supposed to happen, okay? And after prostate cancer treatment, many of these mechanisms are affected. The blood flow is not as good. The venous drainage is not as good. Some people say, well, I can get an erection, but I can't maintain one. It's because the blood is still coming, but if you can't pinch off those veins, then your blood will leak out. It's like you're trying to fill a sink with the bottom of the sink open. No matter how much you turn up on the faucet, it's just not going to fill. And as you talk about the nerves, we talk about, do you preserve the nerves, don't save my nerves, and nerves is also important to communicate with, to maintain normal blood flows. So guys can have blood flow problem from the artery and the vein, and also a neurological problem. And this is why after prostate cancer treatment, our erection is never as good as what we started. So what are some of the other things? It's not uncommon. We have more than one problems. As we get older, our rate of other medical problems goes up too, such as diabetes, heart disease, certain medications that you might take for your blood pressure, and sometimes people can have injury to their back, whether it's in wheelchairs or you're just having disc problems, and those nerves can also affect your sexual function. And lastly, hormonal balance. And cancer treatment is not just prostate cancer. I see all cancer survivors for UCSD, not just for prostate cancer. And then a lot of these other cancer survivors share the same side effects that you have, such as bladder cancer, colon cancer, rectal cancer. And we know that more than half of the guys will need help in their bedroom, okay? So you're not alone. Some of the other things, it's not uncommon. After you get diagnosed with cancer or been treated with cancer, you can still have a little bit of depressed mood, and that can certainly affect your sexual function. It's not uncommon that we usually lose weight after you have cancer treatment, but it's really easy to gain your weight back. So I would see a guy maybe 3 months after surgery, and they're recovering, they lost about 20, 40 pounds. When I see them at a year afterwards, they gain it all back and then some. So there's other healthy lifestyle stuff that can also affect your sexual function. Drinking, some people do recreational drugs, and smoking. So what do we do? So we're going to talk about testosterone. We're going to talk about the pills. We're going to talk about the urethral suppository or muse. We're going to talk about vacuum. We're going to talk about injections. And we're also going to talk about penile prosthesis. I tell every man who comes to my office, I can give you all an erection, just how far we have to go, okay? So we start making these choices together and try to do the right thing for you. If you're a single guy versus you've been marrying for 30 years versus you just married with a 40-year-old wife, everybody's goals are different. So it's not a one-size-fits-all for anybody, and that's why we have a lot of options, and we try to figure out what makes sense for you and your partner, okay? So we're going to talk about testosterone. There are many testosterone options, and the pills is available, but it's only available in Europe. The reason is that when you take a testosterone pill, it gets metabolized in our liver, and people can have liver problems. So that's why oral testosterone is not available in the US. But in other countries, South America or Europe or in Asian countries, you can still see people taking oral testosterone pills, okay? So before we talk about the options, there was a lot of times people ask me, my doctors castrate me for prostate cancer, and now you're going to talk about giving me testosterone? Wouldn't it be kind of like putting gasoline on fire? And that was a traditional belief, okay? Back in the day, we used to think giving testosterone to prostate cancer patients is like putting gasoline on fire, okay? But we now know that it's not healthy to live with the hormones in a toilet, okay? When we're starting to put men on hormonal treatments, yes, their cancer, we can control the cancer, but people were not living longer. They were dying. we're like, well, why were they dying? They don't have cancer anymore, because they're dying of other problems. When you have low testosterone in your body, especially at the castrated level, you start having bone health issues. It's like women going through menopause. You start talking about hot flashes and all the side effects that women goes through. You start having cardiovascular problems. So a lot of people are dying of heart attacks and strokes and breaking their hips and having other complications. So that's why we start limiting the duration we put people on hormones. So the longest you will get hormones, probably 2 years associated with radiation treatment, because we don't put people on lifelong hormones anymore. And we also feel that with more research that giving testosterone to prostate cancer patients is safe, okay? So we will not make your cancer worse. We will not make your cancer come back. We will not lead to metastatic disease and things like that. So, but it is a delicate situation. It's very individualized, and I write more testosterone prescription than any doctors in San Diego. And a lot of them are prostate cancer survivors. We do it for men on active surveillance. We do it for men on post-prostatectomy, radiation. So like I said, everybody is individualized. So we want to make sure balance your cancer control and make sure keeping your body healthy. But these are some of the options available. There's injections, there's topical gel and patches, there's even long-acting testosterone implants. So we usually make these decisions between you and your cancer doctors and myself, and we'll talk about, figure out a regimen that's right for you and make sure that we're achieving the goals that you hope to achieve.
You said only 2 years, right?
The 2 years is for people that's on hormone deprivation therapy. So that's why we don't put your hormone in the castrated level for more than 2 years if we can help it. Because the longer you're on it, that's just not healthy for you. And that's why you might hear about people calling about intermittent androgen deprivation therapy, where they put you on these shots and then they take it off and they put it back on again, so give your body a chance of time to recover. Unfortunately, if you've been on long-term hormone deprivation therapy, means that they castrate you chemically. Even when we take you off the Lupron, the Casodex, most of the guys' hormone will not bounce back to the level that before treatment, okay? So there is some long-term lingering effect of these medications. So we give you, in general, 6 months to a year for your body to bounce back from Lupron, from Casodex and these medications. But if at 1 year your hormone is still not where you're supposed to be, then it's unlikely for your body to make more testosterone on your own, and then we start talking about potential replacement options.
Is the dosage normal for TRT? Any particular limit for prostate cancer survivors?
Great, that's a great question. The question's about the dosages. Is there special dosages for prostate cancer survivors versus regular guys? There isn't, okay? In my regular guys, I'm not trying to make them bodybuilders. I'm not trying to make you guys bodybuilders either, okay? So if you tell me that I want to look like Arnold or look like the people I see at bodybuilding competitions, unfortunately, no amount of testosterone will be able to get you there, okay? They're on different kind of steroids. But you're right, there is safety concerns. So we usually want to make sure your levels are middle of the road, not too high, not too low, okay? And then that's why we have a lot of options, and we'll try to individualize it for every single man to keep you at a safe level. Because there are additional side effects to testosterone replacement therapy. One of them is that it can cause what we call erythrocytosis, or too much red blood cell count, okay? If we overshoot your testosterone level, we're going to overshoot your red blood cell level too. Sometimes the cancer patients are anemic. So that's a good side effect to have, because you need more red blood cells for you to function better. But if your blood counts are normal on the high side, if you have too much and we make a number go up more, your blood gets too thick, we do worry about blood clots. So every man on testosterone replacement treatment, with or without cancer, I monitor your blood count at least twice a year, because there are other side effects that worries me. But to answer your questions, there's not a specific dosages that we put the cancer patients on.
And is this indefinite then?
Yes, so this is indefinite. As a man get older, our hormone level goes down, just like women going through menopause. So your body will not make more hormone in the long term. So if you need help with your hormones. This is no different than diabetics need insulin shot for life. This is no different than people with thyroid issue. They're taking Synthroids or thyroid hormones. This is a lifelong treatment. Yep.
Does the testosterone test have to be done fasting or at any time?
That's a good question. Testosterone test does not need to be done fasting. It is best to be checked in the morning. It's most accurate in the morning because there is certain circadian rhythm to the testosterone testing. So we usually tell the guys to go to the lab ideally before 10 a.m. Okay, unless you work night shifts where your sleep pattern is off, then we have you do your test based on the normal rhythm.
You were talking about the effect of hormone treatment, which can make it permanent. Okay, how long? Make it permanent.
Well, every man is different, but we know that at the minimum, most people receive androgen deprivation therapy, ADT, or your Lupron and your Casodex. It's minimum of 6 months. Okay, so if you choose radiation treatment for your prostate cancer, your radiation doctor is going to put you on hormone deprivation because studies have shown that give you the best chance of curing you of cancer with radiation. So radiation usually are combined with androgen deprivation. So so minimum 6 months. But the longest in somebody with aggressive prostate cancer, they usually keep you on it for 2 years. Okay.
At what point does it affect?
When it becomes permanent?
Yeah.
Unfortunately, nobody really knows. It's really based on your own biology. Everybody, we are all born with a finite ability to make hormones, okay? And depending on what your starting point is, how much can you bounce back? It's different, probably based on your overall health and some genetics as well. So that's why we give every man a chance. We don't just say that you got Lupron and Casodex, you're gonna be on testosterone. We give your body a chance to bounce back. But after about 6 months to a year, when you're off these medications, if your body still has not recovered, then we start talking about helping you. So next thing we talk about are the pills. Viagra, these are medication that came out, decades ago now. I think what these medications have done well for us is that, not that it gives you all an option to treat your ED, is really that prior to these medications come out, you never see a commercial about ED. In today's world, I think you can go all over the world, people heard of Viagra. So the marketing is great. But I think more importantly, they hopefully help all of you become more comfortable talking about your sexual health and ED. So this is not something that you have to be embarrassed to go see your doctor about. Now people are more openly discussing their health in the bedroom, and I think it's because of these medications, because we put these conversations, on the national stage during commercials, and people now are comfortable talking about it. But these medications still available today. Now there's generic options, which is the good news, because previously it's very, very expensive. Most insurance companies think about ED as a lifestyle problem, so it's not life or death. So even for cancer survivors, it's very hard to get these drugs covered. So I think that's one area that, as all of us, both the patients and the doctors, we need to do a better job advocating for ourselves and also for the disease. A woman with breast cancer, not only their cancer treatments cover, a lot of their reconstruction, their breast implants are all covered. But for men, unfortunately, even you have prostate cancer, we're still having a hard time helping you obtain the coverage that you need to help you recover from these treatments. So that's one of those things that we're always working every year. And now we have advocacy groups going to Washington, D.C., talking to senators and that kind of stuff, trying to raise awareness and importance. So hopefully all of you will get the same coverage that breast cancer patients will get. But the medications are available. Now and they all work differently in different people. They all take a little bit of planning. Maybe it takes about an hour for it to work. So you got to take the pills at least an hour before any sexual activity. You got to watch what you eat. If you eat a big greasy meal or have a lot of alcohol, you would decrease the absorption. You just pay $20 for these pills. So let's make sure we take it properly and give it a chance to work. And unfortunately, they all have different, they only last a certain amount of time. So if something happened that night, your partner's not in the mood, unfortunately, you're out $20, okay? So it does take a lot of planning, okay? But if it works for you, it's one of the easiest way to help you restore your erection. There's just a pill, okay? There's even daily dosing. You might see treatment you can take on a daily basis instead of on demand. And we use this for rehabilitation protocols a lot because that helps maintain a certain amount of blood flow to hopefully help your body recover. And these are what's available. The pill is what we call first-line treatment, because if you haven't tried it, let's start with the easy stuff. But unfortunately, most of the guys have had cancer treatment. The pills will not be strong enough, okay? And even if it is, they say, well, the best case scenario, I get like a 50% of what I used to get. It's something, but it's really not enough for me or my partner. So that, and most people get their pills from their primary care doctor. So I rarely actually write prescriptions for pills. When people come see me, they already tried the pills and unfortunately it hasn't worked out properly. That's when we start talking about what we call second-line treatment or what else is available. There's a urethral suppository. Many of you who had surgery probably still remember having the catheter. The catheter is probably the worst experience of any man's life. Those 5, 7 days, 14 days, how many days you have the catheter is probably the most torturous week of your life. But the same place where the catheter go in and out, that's where you would put the suppository, okay? When we take a pill, the pill goes around our whole body. It takes about an hour to find our penis. And then when it gets to our penis, probably only about 5 or 10% of the active ingredient actually gets there. So now we start talking about how do you deliver 100% of the medicine to the area where we need help the most. Suppository is one way of doing it. So basically, it looks like this, and that there's a little pellet about the size of a tip of a ballpoint pen-ish, and you put it at the tip of your penis, and then you let it dissolves locally. So if it works, then it can get you an erection. But unfortunately, it was an option, but in today's world, it hasn't fallen out of favor for multiple reasons. One, it's not as effective. For it to work, you had to use a pretty high dosages of these suppositories, and it burns. So people tell me that, well, it worked. I'm like, great. But I feel like my urethra is burning. It's like I'm wearing a catheter the whole time. So there's no way I can be sexually active with my partner when I have that feeling of a burning urethra, like having a catheter, to do anything. So it's not very well tolerated, okay? And then it's also very, very expensive. So it's probably just as expensive, if not more, than the Viagra or the Cialis. So it can be also cost prohibitive. But in some people, like if you're a veteran, the VA still covers these medications. So it's not uncommon that some of our vets, want to try this because they don't want to talk about needles and syringes just yet. So we do give them a try. But it's still available in the market today, and we just don't use it as much for the reasons that I spoke about. How about a vacuum pump? Vacuum pump, it's one of those like old faithful things that it works. It's a mechanical device. Basically, the pump generates negative pressure, draws the blood into the penis, and that's how you get an erection. Unfortunately, for you to maintain an erection, there's a rubber band called a constriction ring that you have to put at the base of your penis. It has to be pretty tight to be able to maintain the erection. So, as you can imagine, it's starting to get very complicated, starting to get very uncomfortable. And people tell me that it's like you have a rubber band put around your finger, and after a while, you start feeling numb, and it can cause some bruising. So in today's world, we use the vacuum more as a rehabilitation tool, less for sexual activity. But we still use it because in the beginning, when you're recovering from your cancer treatment, you might not be in the mood. You might not say, well, I'm not 100% yet. My sex drive is not there, and I'm still trying to figure out the changes. So we tell them that, well, this is not for sex anyways. Why don't you get a vacuum pump? Instead of we talk about putting needles and pills, just get a pump and use it as a stretching exercise. Because as I mentioned before, after cancer treatment, there can be scar tissue built up internally. But even without, even without cancer treatment, penis is one of those organs that it really follows the phrase, if you don't use it, then you'll lose it, okay? So if you haven't had a normal erection for 6 months or a year, there'll be some changes. So an erection device keep your body stretching. That's why when we were younger, we wake up with morning erections. That's our body's own natural way of stretching, okay? But unfortunately, after prostate cancer treatment, most men are not waking up with morning erections anymore. So this is a way for you to stretch yourself. And studies have shown that it can improve oxygen delivery, which is important for healing. It can also preserve the size of the penis, so which, as all of us know, that nobody has extra room to lose. And you can use it pretty early on. You know, once the catheter comes out, you can start using the vacuum, okay? So it's not something you have to wait till your internal something heals and that kind of stuff. You can start using it right away. And in some people, surgery is not an option and that they fail everything else. Vacuum pumps, mechanical device, it works in almost all the men. Okay.
Even if you have nerve damage?
Even if you have nerve damage, yeah. For most of the guys, injection is what they try after they fail the medication. And this is probably the joke that I told 7 years ago. When I tell people about injections, they look at me. First, they don't think I'm old enough to be their doctor. And secondly, they definitely don't think that I know anything about ED. What do you know about ED? You know, you look like you're 21. And then third thing, there's no way I'm putting a needle in my penis. You know, you're crazy. You know, so this is what conversation I get to have every day. Okay, but yes, it is crazy. I am asking you to put a needle in your penis. Okay, it's really no different than diabetics giving themselves an insulin shot. Okay, it's a needle. It's a needle. It's the same type of needle. It's a couple drops of medications, but you're right, it is different because it's going to the very sensitive part of our body. It's not just in our belly fat area. But it works, okay, in the guys who can handle it. It works in 90% of the guys. So I'm not worried about it not working. I'm worried about it working too well. Because if we're not careful, you give yourself one drop too many, you can have an erection lasting longer than 4 hours, called priapism. We hear about that on the commercials. For most of the guys in this room think that's a good problem to have because you're having a hard time with erection to start with. You say 4 hours sounds pretty good. But unfortunately, it's not, okay? It's an embarrassing trip to the emergency room. What happens when you have an erection for more than 4 hours is that the blood flow that's there starting to clot. The blood doesn't drain, and it becomes painful. And then if you think the needle to inject to get you an erection is big, when you go to the emergency room, either me or one of my residents or an ER doctor will put a needle about 10 times the size to drain the blood, okay? So that's why we had to be very, very careful when we use these medications. And we usually do the first injection in my office because I usually assume most men have never put a needle in the penis before. So there's some teaching involved. So we try to do it properly, so hopefully it will minimize your pain and suffering. But most importantly, I want to make sure you don't have an overdose reaction. So we try to figure out the right dosages for you before we cut you loose and let you do it on your own. The ideal response with the injection is that a man give himself a small injection. They start the foreplay process. Within about 5 or 10 minutes, he should generate an erection. So this is not like the pill, you have to wait an hour. An erection should not last longer than 1 hour. And after he climaxes, the erection goes away. That's the right sequence of things. And we help you figure out what that dose is, and we especially want to minimize the side effects. In people who are afraid of needles and syringes, there's a thing called auto-injector, where you just put everything in the, draw out the medication, all that kind of stuff, and you push a button, and then the contraption give you the shot. So you don't even see the needle going in or anything like that. So there are things that we do. And what's the medicine are different vasodilators. And these are some of the formulations available that you might hear about it or doctor might talk to you about. But it works in most of the guys as long as you can tolerate. You don't faint. We have guys who cannot give themselves injections, but their spouse or partner are nurses or other people that are very motivated. So they say, no problem. I'll do it for him, you know, so that both husband and wife would come, and then we would show both of them, and then it's not uncommon the spouse or the partner is the one that gives the shots, and actually not the men themselves, because we know that, you know, women are tougher than us. So how satisfied our people are with all these things? In general, 40%, it's hard to see. The first one is talking about satisfaction for injections. For injections, about 40% of the guys are happy. Because in general, even though it works, it's a needle, you know, in your penis. So not everybody want that, and I understand. The pills, about half the guys are satisfied. Usually people are not happy because of ineffectiveness, because of cost reasons, and sometimes there's a lot of planning involved that they're not happy. But when people try these things, they end up having surgery. 90% guys are satisfied. But this is probably a little bit of a selection bias, you know, because these people usually have tried the other treatments already. So, and a lot of times they fail the other treatments already. So the surgery obviously is something that's effective, so they're happy. Even though the most recent guidelines talk about we don't have to go through all the steps that I talked about to have surgery, in today's world, we still have you try the non-surgical options first. Because obviously, if we can help you without surgery, that's the best. But if you do need help with surgery, we're also here to help you too. You know, I think that's the difference between what we do and versus some other doctors, is that we're able to offer you everything from A through Z. You know, we can help you from the easiest form to the most difficult form, okay? One of the things people was always very intimidated with surgery is that if I can't even afford the pills, how can I afford surgery, you know? But in some crazy world that we live in, even though the insurance companies do not cover Viagra or Cialis, they will not cover the suppository, they will not cover the vacuum pump, they will not cover the injection shots, but they will cover surgery, okay? So you don't have to worry about cost when you're thinking about surgery. So what is surgery? Basically, and that's what I do, you know, I do about 2 or 3 surgeries per week, 50 weeks a year, and so we do a lot. Surgery is basically, instead of your body generate an erection, I do it for you with an implant. And this is what it looks like. Essentially, it's called multi-component or inflatable 3-piece prosthesis. So it's a hydraulic system for the engineers in the room. People always want to know how it works. There's fluids that travels, and that's what fills the implant. Essentially, there's water balloons. I put 2 water balloons inside your penis, and it's controlled with a pump. Okay, everything is hidden inside your body. And the fluids normally are kept in what we call a reservoir or another water balloon. Okay. Normally, since 90% of the time a man spend with their penis flaccid, the water balloons are empty. Okay, so it feels natural, it feels normal, just like how you feel now. When you want to have intercourse, you pump the fluid from the reservoir into the fluid and then come out. And it fills the implant with sterile saline. Once it's full, you have intercourse. You have intercourse for as long as you want. Even after you climax, the implant is still up because the water balloon is still full. When you're done with sexual activity, there's a release valve. There's a button that drains the fluid back into the water balloon. Okay, so this is how the mechanics of it work. It takes about an hour, and you spend 1 night in the hospital. So this is kind of like where the implant sits. You can see the 2 long cylinder type water balloons in the penis. There's a pump in the scrotum next to the testicle, and there's water balloon in your belly. So it goes soft normally, and when you want to have intercourse, you would pump it up. And this is what it looks like. At rest, it's soft and with an erection. Okay. So for the most part, I don't offer surgery to people who I make them try injections and I make them try the pills. You have to at least give it a try. You don't have to try it for a long time, okay? But just give it a try and don't just poo-poo it or whatever, you know. But if you tried it and that's not satisfactory to you, or you can tolerate it, or you're not getting the right response, then we talk about surgery. We've been doing this for 30 years. This was actually invented at Baylor, where I did my training 30 years ago. And there's been multiple modifications now. Now this is fancy silicone. Now the implants are coated with antibiotics to decrease infection. And for the most part, it works. And the lifespan of it is about 12 to 15 years. So I tell the guys I see today that 12, 15 years from now, this is going to stop working. You're like, why? Because it's a hydraulic system, but usually the reason for mechanical failure is that the fluids leak out. So what happens is they will pump and nothing's going to happen because there's no more fluids. It's saline, so it's safe for your body, so you will not get sick. This is not like silicone breast implant that people can get sick from it. But unfortunately, without the fluids in there, the hydraulics doesn't work. So if 12 years from now, you tell me that, you know, that part of my life with my partner is over, does it matter to us anymore? We don't have to do anything. You can actually live with an implant inside your body. You can take it to the grave with you. You don't need to have it removed. But if 12 years from now, you tell me that, you know, I don't know why my wife still want to be with me, and then I got to keep her happy. So you will need, and how do I make this work again? Can you just add fluids in there? The answer is no, okay? We do have to do a replacement surgery. So we'll take out the old implant and put a new one in. But for the most part, it should last you 10 or 15 years. The person that I have seen with the longest implants, about 18 years, and then it's still working. But there is a definite lifespan of the implant. So that's what's available for erectile dysfunction. So these are some of the athletes you might or might not recognize. So all these athletes have surgery, and then to get them back to their normal shape, they undergo rehabilitation. So the last part of my talk, we're going to talk about rehabilitation. Back in the day, we used to say, you know, Mr. Jones, you survived surgery. It's going to take a year or a year and a half for your body to heal. Go home. I'll see you about a year and a half later. Whatever your body cannot heal, we see you back, and then we can help you. We now know that's probably the wrong approach. You are not any different than these professional athletes. The only way to get your body back to your pre-treatment shape is to rehabilitation, okay? So now, then this is not a new concept anymore. 7 years ago when I came here for the first time, most people have never heard of this, and most doctors did not offer this to them. But in 2019, if a cancer doctor did not discuss rehabilitation with you, that's actually kind of an outdated way of taking care of all the cancer survivors. So now what I do as part of the cancer survivorship program at UCSD is that we rehab you. You know, we treat you like Tiger Woods, like any professional athletes. We're going to try to help you. So hopefully when the healing process is done, you are as close to your shape you were before surgery or radiation. So what's the goal? The goal is to preserve the tissue, which is the smooth muscle inside your penis. We also want to preserve endothelial function, which is the blood flow, okay? And then we also want to optimize the nerve recovery, even if the doctors say that they save your nerves, which you will hear a lot. We say, were you able to save my nerve? The answer is yes. But by saving your nerve doesn't mean there's no injury to the nerve, okay? That just means that they did not cut it, they did not take it out with your prostate, but there's still surgery. There could be cautery artifact from thermal injury to the nerve. It could be stretch injury to the nerve. So there's some healing for the nerve as well, okay? And so things we do, we use medication, all the things that we talked about, you know, the medications, the injections, the suppository if you need it, the vacuum pump, and if you need hormone replacement, because your hormone never bounced back from your Lupron shots or your Casodex, we also give you help, okay? So before surgery or before radiation, we try to put you on a low-dose oral medication to start improving circulation. And this can be Viagra, this could be Cialis, anything. We basically try to find the best cost-effective option for you with minimal side effects, because we want to keep your blood flow going. Because you're going to be like, I'm not in the mood, you know, why are we trying to talk about sex or anything, you know, I have cancer and I'm not ready. But this will help you in terms of keeping the blood flow going. And then hopefully we can get you a morning erection once in a while with these medications. And then once you're about a month after you're done with surgery or radiation, we start talking about the vacuum pumps or higher dosages of the pills or even suppository if that's tolerated. If you're not getting normal erection 3 months after treatment, we start talking about injections. Because like I said, this is one of those things, if you don't use it, you'll lose it. So we want you to start getting erections as early as possible, even if you tell me that I'm not in the mood, because that's what's going to give you the best chance of healing. And studies have shown that early, even if it's medically induced erection, leads to better outcomes at 16, 18 months after treatment. So that's why it's important to get this started early. And then at about 6 months after treatment, we start checking your testosterone level. We want to make sure you're cancer-free, your PSA is stable. And this is no different than active surveillance patients. You know, if your PSA is stable, we now do MRIs, we do various things to make sure that there's no changes to your cancer. Then we think it's safe to give you testosterone at approximately 6 months after your diagnosis. And at about a year, at 1 year, 90% of the healing is done, okay? So it's very rare people say, I have nothing at 1 year, and a year and a half, I'm back to normal, okay? So this is a process that improves with time, you know? So usually at 1 year, if you're still not getting the sexual function that you hope to be, we start talking about surgery. But I usually give you at least 16 months, a year, and about 4 months or so, a best chance of recovery on your own before we actually do your surgery. So so that's kind of what the timeline might look like, and this can be replaced with radiation. This can be replaced with chemotherapy. The timeline doesn't change. It's just that, you know, everybody needs different amount of help at different stages. But there are various milestones that I expect you guys to hit, you know, during your recovery. So if you're not there, that's when we adjust the treatments for you. But that's kind of how, that's why I see the guys, you know, 1 month after treatment, 3 months, 6 months, at about 1 year. So that's what it's like. So this is my last slide, and then we can answer as many questions you want. So I want you to know that sexual problems is normal to all cancer survivors. It's not just unique to prostate cancer. We have a lot of treatment options we can help you, and rehabilitation in 2019 is really a very critical part of how we take care of cancer patients, and that we give every man a chance, and your best chance is to rehabilitation. Any questions?
Okay, thank you. Wasn't that interesting? You learned something? I think you're particularly interested in the more questions on testosterone. We have a gentleman here who is on testosterone. I asked him this morning how he's doing. He's fine. He's great. He's got energy. Things like that. So, let me ask you a question. I heard at a prostate cancer meeting, the frequency of ED for most men is if you're 50% have ED, if you're 60, it's 60%, and so forth, all the way up to 90. Is that accurate?
Yes. So this, like I mentioned before, erection problems is common to all men as we get older. Like you said, 50% of guys at age 50 needs help. 60% at 60, 70% 70. So even if you did not have cancer treatment or prostate cancer, you will need help anyways, okay? Back in the day, we used to say that's normal part of aging. You know, it's normal for grandpa to just doze off, you know, after dinner, and then, you know, just let him be. But in today's world, we're living longer, and most of us want to age well. We don't want to just accept aging as aging. So, so that's why erection is one of those things that is a disease of aging. If we live long enough, we will need help. So you're right about the prevalence of erectile dysfunction.
I want this group to know that, and if your urologist is over 50, guess what he has? He has ED too.
That's why he won't give you any samples, because he's keeping it for himself.
And that's why they are not necessarily forthcoming and want to discuss it these days. So if you want to talk about it, you know, you have to bring it up to your doctor, and it could be a help to you. So don't be hesitant to ask questions. Let's start over here. Any questions? Yes, sir.
Yeah, can you go back about 3 slides? You said treatment for, right there.
Okay.
Forward one more. Treat anorgasmia.
Mm-hmm. So anorgasmia, as the name implies, is trouble with orgasm. It's not uncommon. So we start thinking about these things as like, sometimes terms are very confusing. People think they can get an erection, that means they can climax, okay? Some people think that if I can't get an erection, or if I lose my ejaculation, that means I cannot climax, you know? So there are actually very, very different processes. And prostate cancer treatment can affect it differently. So as I mentioned before, erection is talking about blood flow. If you cannot get an erection, it doesn't mean you cannot climax, okay? Unfortunately, after prostate is removed or you have radiation, usually people don't ejaculate anymore, okay? And so they have what we call anejaculation. That doesn't mean you can't get an erection. It doesn't mean you can't climax. It's its own thing. It only means you cannot have kids anymore without help, okay? The last part, climax. People can not have an erection, but still climax normally, okay? Climax is in your brain. Your orgasmic function is having to do with your brain. It has nothing to do with your erection at all. But it's an interesting phenomenon that's not very well understood. Some people tell us that after they have prostate cancer treatment, it takes a long time for them to climax. It's called delayed orgasm, or they cannot climax at all, okay? So but you're like, well, you didn't do anything to my brain, at least as far as I can tell, you only did work on my prostate, right? So it's poorly understood. I don't know how much of it is neurological input versus a psychological or a neural changes after cancer treatment or diagnosis. People can get depression and various neurological changes after cancer diagnosis. But how we help men is that it's very difficult to treat. There is a hormone, a neurotransmitter in our brain called prolactin, okay? You might hear about women with prolactin because that's when a woman have a baby. Prolactin is the hormone that induces a woman to make breast milk so they can breastfeed their baby. But prolactin is in men's body too. Prolactin is normally released during refractory period. So after a man climax, there's a period of time we cannot have any sexual activity because our body secrete this hormone called prolactin to tell us to relax, take a break, okay? You need to recharge before you want to go again. And so prolactin is a negatory hormone to our body to tell us to slow down. So we can use medicine to block prolactin secretion in the brain. So you have less prolactin in your body. Hopefully will help you improve the ease of achieving orgasm. It works in about 1/3 of the guys, but there is medication available.
Okay, question over here. Yes, sir.
About the ADT and libido. Okay. ADT suppress libido,
Yes.
and just so how you overcome that.
Yes, so most men on ADT is not going to feel well, okay? Because they're castrating you. So when your testosterone level is 0, or less than 5, whatever the lab value you can measure down to, you're not going to have any sex drive. You're not going to get normal erections. You're going to feel weak. You're going to get hot flashes. You're going to potentially gain weight. You can get nipple tenderness. Unfortunately, while you are on ADT, we can manage some of the side effects such as hot flashes and give you more help with erection. We cannot bring your libido back until we help you with your testosterone. So there's nothing we can do to help you with libido during ADT because that's a direct relation to your testosterone level. So until you're done with ADT, your body's able to bounce back some. Or if we give you testosterone, then that's how we help you. But during ADT, unfortunately, the poor libido is a known side effect.
Use that testosterone while you're on ADT?
Usually not, because that kind of defeats the purpose, because during that period when they're doing ADT, they want to starve your cancer cells from testosterone. So once the cancer cells are all dead or they're all under control, then giving testosterone is safer. So usually not.
Let me bring up the subject. It's called dihydrotestosterone. Yes. When I came here 12 years ago, I was on Lupron and it devastated me. And then Gene and some others say, what you ought to do is take Avodart and Cassidy. And I did that. My testosterone was over 1,000. My dihydro was 0, and I had a sex life. And my PSA was 0. And then over time, I had to take, Lupron, I took Firmagon. By the way, Firmagon really means firm is gone. But I don't hear anybody talk about dihydrotestosterone anymore.
Yeah, well, it's kind of people are trying to stay away from a lot of the hormonal treatments because as you probably going to have a speaker talk about castrate-resistant prostate cancer, meaning that we now know that hormone can help you with your prostate cancer, but it's not a good long-term treatment in terms of your quality of life and also cancer control. So that, and people have tried various cocktails of, do I block testosterone? Do I block dihydrotestosterone? Do I do intermittent hormone deprivation? Or sometimes they do what we call bipolar, meaning that they lower your testosterone, and then they give you too much testosterone in this up and down fashion to almost shock the system to control cancer. So I think this hormone treatment for cancer control is still evolving. That's why you see so many new drugs. They're usually very, very expensive, but there's a lot of ads on the commercials. So that means we haven't really figured out yet. But we do know that if we keep you on androgen deprivation or ADT long enough, the cancer will also develop resistance too. That's why when you start talking about castrate-resistant prostate cancer, meaning that those now all of a sudden testosterone, starving them of testosterone is not enough anymore. You know, now they start doing chemotherapy and various other drugs. So some people say maybe I should just take medications like Avodart or Proscar or finasteride to protect me against prostate cancer. And that's been also studied as well, and it hasn't really panned out as a drug to prevent cancer either. So, but it's evolving. So, but that's why we try to balance cancer control and also make sure you still maintain your quality of life.
Okay, any back there? Yes, sir.
How effective is acoustic shockwave therapy for ED?
Okay, that's a very good question. The question is about shockwave treatment for ED. And as many of you know, probably have seen the commercials on the TV or the paper about shockwave. So the idea is that by using ultrasound shockwaves into the penis, you can regenerate it. This is the same concept as stem cells or PRP, plasma-rich proteins. You might have heard about all these treatments. Unfortunately, it's very experimental, and it's not FDA approved, and it's purely done in these for-profit centers currently. It's been used, however, internationally for a while. And when I go on international meetings, I have heard some mixed results. In general, it can potentially work in guys with mild erectile dysfunction who used to take Viagra or Cialis, and as they get older, the Viagra and Cialis stops working. So then by undergoing shockwave treatment, all of a sudden the pills can start working again. That's probably the situation where I have heard positive results. Unfortunately, in people with cancer treatment or cancer side effects, your body is battling more than just the normal aging process. You also have the side effect of treatment, the nerve injury, the blood flow issues, so it's probably not gonna work. But with that said, we're still doing research, and then since the Men's Health Center is open, we're starting a study looking at shockwave in men with erectile dysfunction, and it's gonna be a placebo-controlled study, so you might get the shams treatment, but it's gonna be free, okay? So once we get it all set up, then we will advertise it, hopefully to the group. So if anybody's interested in participating, we're happy to get you all involved, but unfortunately, specifically for cancer survivors, that's probably not gonna be the ticket for you to get you back to your pre-treatment shape.
Okay, question here.
Yes, I've heard of a priapus shot or P shot. Is that on your radar?
Yeah, so that's kind of the P shot or the private shot. Those are kind of falls in line with the stem cells, the PRP. You know, you might hear about athletes getting it injected in their knees, like, or back, you know, and some people swear by it, some people don't swear by it. But unfortunately, for erection problems, it hasn't really panned out. So save your $1,000 and don't waste your money.
Okay, in the back there.
I was wondering about, you said low testosterone also creates different problems. Is that right, like in cardiorespiratory?
Yes, so we know that people on long-term ADT, where they have very low testosterone level, they're at increased risk for cardiovascular events, and they're more likely to get strokes or heart attacks, and they're also weaker, so they have decreased activity level. They're more likely to gain weight. They're more overweight. They can also have bone health complications, where their bone is no different than women after menopause get osteoporosis. So if you fall, or you can break your hip, and so these are some of the complications of having low testosterone for prolonged periods of time.
Is there a counter for that? I mean, I'm going through hot flashes, and now he's going through it, and irritability and insomnia. Have you discovered what can counter that?
There are some medicine we can use to treat hot flashes. They're making it called Megaze. So there are some medication we can use to treat. But unfortunately, some of these side effects will have to ride it out until you're done with the hormonal treatment. Because obviously we cannot, and so that's why we used to give estrogen replacement treatments for women going to menopause, and because we try to do the work that your body cannot do anymore. And in today's world, we still do, but it's a little bit controversial. You want to make sure that your heart is healthy, because they worry about blood clots as well. It makes sure you don't have breast cancer and all that kind of stuff as well for women. But for men, we do. It's true. When you have low T, you don't feel good. It's more than just sexual function. People have decreased energy, irritability, like you say. They have cognitive function declines. Their mind isn't as clear. They call it a brain fog. They can't remember where they left their keys. They can't remember people's names or phone numbers. So there are other whole host of quality of life issues, not just sex. So that's why we try to minimize the duration of any time we keep your body with hormone imbalance.
Okay. Yes, sir.
You use the term long-term ADT. I have serious heart situations, stents, diabetes, and they're recommending 6 months of ADT. Is that a long?
No, 6 months is probably the standard. Everybody, if you were to get radiation, 6 months is standard. That's what the study shows, that if you do radiation alone versus radiation with 6 months of ADT, the cancer control is better when you combine the radiation with ADT. 6 months is not considered long-term. There were people, I'm sure you remember, the prior group members that come here, they were getting Lupron shots for life. They would go to the doctor's office and just get the shots every 6 months, every 3 months, and then there was like no end in sight. That's what long-term. But 6 months is not considered long-term. It's standard.
For the heart issues, that's only if it's long-term?
Exactly.
Okay.
Yeah.
Okay, question.
Yeah, does the testosterone treatment causes cancer to come back?
It does not, okay? So we now know that, so that's the old school way of believing it, but there people have given testosterone treatment to people with high-risk prostate cancer, Gleason 8, Gleason 9, Gleason 10 disease, and have found that there's no difference in recurrence rate or rate of metastatic disease. But with that said, we still want you to have your cancer treated first. Some people might say, well, I don't want to have my cancer treated. I just want my testosterone. I don't think that's right either, okay? But once you get your cancer treated, we're very comfortable, because the thing is that if I give you testosterone, that can kind of, in some ways, can alter your PSA, and that can make the cancer doctor have a hard time monitoring your cancer sometimes too. So once you get your cancer treated, once we know what your PSA is supposed to be and it's at the expected level, then giving you testosterone can monitor you better. Yeah, but so I will withhold testosterone to patients who needs cancer treatment but doesn't want to have it done yet, because I still, even though it doesn't cause cancer to spread or get worse, we don't want to ignore cancer either, you know. So we do recommend people to have cancer treated first if they need it before we give them testosterone. But active surveillance is different. If you're on active surveillance, your cancer is under control and they're dormant, they will not change.
Why do certain doctors still believe that?
Well, the reason is that it's medical legal in some ways, because they don't want to get sued. So that, you know, God forbid, you know, you have a recurrence, and that you don't want to get sued for giving you testosterone to cause the recurrence. You know, people might get sued, so that's one reason. The second thing is that, you know, it's one of those things. You know, there's not every doctor believe in rehabilitation protocol. You know, some people still feel like treating your cancer is the only priority. They might not prioritize your quality of life and your urinary sexual function as much as you and I prioritize that. So I think that's why it's important to discuss just like, you know, we discussed. That's why you're here. You're informed. You want to discuss all your goals with the doctor, and then they might be more open. Maybe the doctor didn't know that those things are important to you. You know, then they're just happy that you're cancer free. You know, so and that's why at UCSD we have cancer doctors that do nothing but cancer all day, and there are people like me take care of cancer survivors, because we have different priorities. And sometimes, you know, our priorities, there's things we do at diagnosis, there are things we do at treatment, and there's things we do at your recovery for your long-term quality of life. So that's why it's a team of us. It's not just me. You know, we have a bunch of people that we all work together.
Let me just comment. You have a fellowship at Baylor.
Mm-hmm.
Baylor is one of the leaders in considering testosterone, is it not?
Well, yeah, we do a lot of research, but now that there's research coming out of Memorial Sloan Kettering, out of Johns Hopkins, you know, I mean, in Texas we have MD and Anderson, so we have a lot of cancer patients. But this concept is
not in Southern
exactly.
California. There's a different in attitude about that down here versus LA.
Yeah, probably. Yeah.
And people, he's in a more modern world.
Mm-hmm.
Okay. Back there, and then you're next.
You, sir.
You, yeah.
You.
Me? With testosterone treatment, does that inhibit the body's own production in any way?
So the question is about, does testosterone treatment inhibit your body's own production? The answer is yes, okay? When I give a man testosterone, or if I receive testosterone, my body gets lazy. It starts making my own hormone and start making my own sperm. Half of my job at UCSD is to help people to get pregnant, because I also do infertility. And a lot of the infertile men have hormone problems too. And I cannot give them testosterone because their body start making their own hormones and sperm. So giving a man testosterone is like giving them birth control pill. That's why you hear about jokes about bodybuilders with testicles the size of raisins, because they all shrivel up to nothing. So you're right, when I give you testosterone, your body will most likely stop making your own hormone, okay? That's why these treatments are lifelong, and that's just a known phenomenon.
Okay.
Doctor, I am on hormone therapy, and gradually my hot flashes got more and more. And I was talking to some of the guys in the group, and they recommended gabapentin. And my hot flashes are minimal now.
Great.
Because that's something. Pardon me?
Gabapentin.
Gabapentin. Gabapentin.
Yeah. It's either gabapentin or Neurontin, and these are drugs that are used to control neurological pain. So, but there are various medicine you can try to mitigate. But unfortunately, it will not go away until you're done with the ADT.
The second part is.
Thank you for that. You have a question?
I do. Now, I've heard that if you're on, and it's all an individual thing, if you're on ADT for like close to 3 years, you're not going to come back.
Even 6 months, you might not come back.
Okay, so.
That's not okay.
Pardon me?
That's not okay.
I'm just saying, okay, that I understand.
Yeah, exactly. So unfortunately, most guys, you know, most people with prostate cancer, you're probably in your 50s and 60s and maybe 70s, or 80. No, I mean at the time of diagnosis. So most of guys already have about 30% of guys age 50, they already have a decline in their testosterone level. That means that your body is going to stop making testosterone, or making less and less and less. So you can imagine that, you know, if you're 18 years old at your prime, I can knock down your hormone, your body can recover better. But when you're already not 100% at age 50, and then I'm going to take away your hormones and ask your body to bounce back, you probably aren't going to bounce back very well, okay? And then that just, you know, just is no different than you pull your back today versus you pulled your back when you were 16 in high school, you know? So the recovery after ADT is not great, you know, but we do give your body a chance. You know, we give you 6 months to a year to see what you can do, you know? So because if you can do enough work on your own, we don't need to give you medicine that you don't need, you know? But the take-home point is that if you do need help, there's a lot of things we can do, and now it's acceptable for you to receive testosterone if you need it, even if you have prostate cancer.
Okay, question there.
If you're on injections for a long period of time, like I've been on injections for 10 years, is there a cumulative damage from using the Trimix mixtures? Because I've noticed that not only the strength, but the dose has to be increased, and I'm 78 now, and it's not working.
Okay.
A large dose.
Good. So the question's about injection treatment for ED, and do you over time what happens? And so it's not uncommon that guys start taking Viagra in their 50s, and then into their 60s they start doing injections, and then in the 70s they talk to me about surgery. And this is not just cancer patients, because as we get older, our body need more help. Okay, so it's not uncommon that you have to go up on the dosages. Maybe when you're in your 50s, you're just starting to take Viagra, you bite off a little bit of the pill, and that's all you need. And then they're 60, you're taking a whole pill, and you still need more help. It's not tolerance, it's just your body's circulation needs more help. So if you were doing injections, there is a lifespan of how long these medicine will probably work for you, okay? This is irrespective of cancer patient. If you happen to have diabetes or other comorbidities, then that will accelerate the process a little bit more, you know? But if you had a 10-year run with the Trimix, it's probably time to bump it up to something called Quamix, okay? The medication can become more potent by adding more ingredients to it. So Trimix, as the name implies, has 3 ingredients. And then we have one more medication called Quamix. We add a 4th ingredient to it. That's unfortunately the end of the road for the injections, because we don't have something with 5 or 6 or 7 or 10 ingredients. So, it's not uncommon. People need more help with time goes on. And some people do tell me that they can have scar tissues from injections, and scar tissue can cause deformities. But scar tissue also makes it hurt less. So after a while, people say, it doesn't bother me anymore, it doesn't hurt anymore. So we do have to be careful about scar tissue. Sometimes it can help and it can make it worse.
The scar tissue is detectable, so is there any, what would you call it, undetectable type damaging being done by the injections over?
Not really. We tell a guy usually to alternate side to injections, but most men are dominant in their right hand or left hand, so you probably end up using your dominant hand majority of the time anyways, you know. Unless it's causing you problems, we just let you do the way that's convenient for you. If you're still able to achieve the response that with the right dosages, we don't try to interfere with it.
Yes, sir.
I was wondering, what's your opinion about proton
Proton beam?
radiation therapy? They claim that there aren't key side effects.
Yeah. So proton beam. Questions about proton beam therapy. Proton beam is a form of radiation treatment. Okay. It's a very intense radiation treatment. So the pros of the proton beam is that it's more powerful than standard radiation, and so you need less treatment. You don't go through as many weeks of the radiation treatment. And in terms of cancer control and side effects, there's no difference in cancer control. If you undergo standard radiation treatment or proton beam, the cancer control is no different. Unfortunately, the side effects are usually more severe, okay? Because you can imagine that now we're zapping your prostate with something that's 100 times more powerful than what we used to do. So any collateral damage, whether it's in your erectile function, in your GI, in your bowel movements, or in your bladder, that can be more severe too. So that's one of those things. But there's a lot of marketing for it, because there's a lot of marketing for it. Just down the street, we have a $1 billion proton beam center. It takes $1 billion to build a proton beam center. So it has been shown that in certain cancers, such as brain cancer in kids, it's great, okay? But for prostate cancer, it's really not that different than standard radiation treatment.
Okay, yes, sir.
Would you comment on HIFU then?
Yeah. So HIFU is another form of treatment for the prostate cancer. There is a movement toward what we call ablation of the prostate. Before, when you have cancer, we used to just treat the whole prostate. Now we're talking about focal therapy. You might have heard about that, meaning that if you only have prostate cancer that's detected super early, just one spot in the prostate, why do we have to do the whole thing and give you all the side effects of treating the whole thing? So HIFU cryotherapy has emerged as a treatment for what we consider focal therapy, meaning that if there's a very small spot in your prostate that have problems, let's just zap it for now. With either we can freeze it or we can put HIFU onto it, and then by not treating the whole prostate, you have a lot less erection problems, a lot less urinary problems. So that has kind of become, so that's been used for that treatment effectively. But if you're gonna treat the whole prostate with HIFU, it's really no different than treating a whole prostate with radiation or surgery. That's why we use HIFU or cryotherapy, where we freeze the prostate in what we call in a focal therapy treatment.
Okay, I've got a question here, yes.
I went through the proton treatment and I'm on Lupron now. Did I hear you correctly? If you're on Lupron, you're wasting time trying to do anything with creating erections.
He was on Lupron, and he said it's a hard time to create erections after Lupron. Was that your question?
Well, when I asked you, is there any point to going through the
So is there any point going through rehabilitation protocol? Yeah, so for you, specifically, you have gone the radiation, the proton already, and you're on hormone deprivation. So now we're not really in a recovery mode because you're still undergoing treatment, you know? So most men, when you're on ADT or Lupron shots, the Viagra, the Cialis, those pills are not gonna work. Because for those pills to work, your hormone has to be in balance, okay? So when your hormone level is low, it's more, when you take a pill, you're not gonna get the maximum response. So the only way for you to have an erection is generally with injections or surgery, okay? So I would not try the pills. I would consider doing either one of those two.
Yeah, it would seem to me that if you had radiation, whether it would be a proton or some other thing, that you would want to take your ADT, Lupron, or whatever, maybe a month or two before you started the treatment, and also keeping it into the, coincidentally, when you're on the radiation therapy. Did this fellow say that he's having a Lupron after he has the?
Yeah, so for most of the standard protocol is 6 months of ADT plus the radiation, standard radiation. Yeah, it's kind of, it's every, yeah, there's no, I mean, obviously, every doctor has his own protocol, you know, but the key thing is not necessarily timing. The key thing is that you combine two treatment options. So, but like I said, proton is a new high-dose radiation. People are still figuring out what's the best way to use it, and they've been experimenting with different type of cancer, and prostate cancer is one of the things they're still learning.
I got it 21 years ago.
All right, let's go over here. Try it.
I just want to make one comment about the gabapentin or Neurontin. I've used it for quite a number of years to control hot flashes, and I have very few now.
Okay. Anybody pass there? Yes.
Yep. Doctor, in your surgery slide, you showed a penis that was fairly normal. Is it normal in older people that the penis shrinks? And is there a limit on penis size?
So the question's about size of the penis with surgery. So as you imagine, your prostate was part of your normal anatomy. So once they remove your prostate or they shrink your prostate, things are going to shrink, okay? When we remove the prostate, whether robotically or open surgery, there's two ends, the bladder and the urethra, we connect, right? So there's a gap. By reconnecting the gap, your penis is going to be at least 2 to 3 inches shorter, okay? That's just normal anatomy, right? If you remove something and you connect the two ends together, there's going to be lost size to start with. And the second thing is that most people don't get normal erections after treatment. Your penis also shrink because of it. The number one reason people is not happy after penile implant surgery is their size, okay? This is different than breast implant. A woman can go into a plastic surgeon's office, demand to be whatever size she wants to be. A plastic surgeon will make it happen. I cannot do that, okay? So I do rehabilitation protocol. Hopefully you will lose less size than you otherwise would have. But your erection with surgery will never be as big as your 18-year-old erection. People always compare themselves to their 18-year-old self, you know? But if you have surgery, you will not. So basically what I do is that during surgery, we measure you internally, not just outside with a measuring tape, okay? People like Christy and then the medical devices, they will come and we have implants of various sizes. So we customize one that fits your body. If I put one in that's too big, you have problems. If I put in that's too small, you got problems too. So that's why we measure you. And so your size after surgery is not going to be smaller than your size before surgery. But unfortunately, it will not be when you're 18 either. That's why we try to help you generate your natural erection the best that we can, because that will always be bigger than your surgery erection, you know. But luckily, through the rehabilitation protocol, most men don't lose any more size. So even if you end up having surgery, you will get a functional result.
Okay, let me just ask you, you are also helpful in the incontinence. Besides right? You want to say a few things about this?
Sure. So like I said, there was the 3 goals. One is the cancer control, that's number 1. Number 2 is not erection, it's urinary control. While we like to think sex is important, we probably have sex not as frequently as we go pee. You know, we gotta go pee every day. You probably don't need to have sex every day. Maybe some people do. And then the third thing is your erection. So the second priority is your urinary control, okay? It's important to do your Kegel exercises early, okay? Because that's the only thing during the rehabilitation process. I didn't put that in because that's not part of the sexual function, but when we see the guys, we also talk to them about Kegel exercises. For some reason, if I tell a woman to do Kegel exercise, they don't know how to do it properly. When I tell a guy to do Kegel exercises, they start doing abdominal crunches, they start squeezing their butt, they think that's Kegel, but all the women in the room knows that's not, okay? So the best feedback for doing Kegel or Kegel exercises properly is that when you go to the bathroom, midstream while you're peeing, you stop the stream, and then you pee again. That's the best feedback you have. Once you learn how to do that, then you do it while you're driving, you do it when you're watching TV, you're doing it during dinner, you can do that whenever you want, okay? In people who still have a hard time figuring out how to do it, we actually have pelvic floor physical therapists that actually can help you do feedback exercises to make sure you're doing it properly. Because we only have a year to get your urinary control back. So if you're leaking at 6 months, that's not a good sign. So when I check in with you with these milestones, we also check in with you on your urinary function recovery, okay? At 1 year, what you have is what you're gonna have, okay? If you have surgery and then you have radiation, for sure you're gonna leak, okay? Because that's 2 insults to your body beyond just 1, okay? But there are many things that we can do to help you with your urinary control, okay? It ranges from injections into the urethra to help you pee better, but that's usually short-lived. We also do sling surgery to help men with mild leakage. That's usually guys with 1 or 2 pads per day. In guys with more severe form of incontinence or have prior radiation, then we do what we call an artificial urinary sphincter surgery to recreate the muscle that's damaged to help you with urinary control. So unfortunately, most of the help after the healing process is done is usually a surgical procedure. But you do not need to wear a diaper for the rest of your life. There are a lot of things we can do, okay?
Since the same guy that invented the penile thing, invented
it's similar, yes.
Since we're talking about exercise, as far as testosterone level, exercise like going to the gym, walking, running, is that any way preventative as far as we age? Does our testosterone level go down because we're just more active?
Yeah, so the question about exercise and aging and testosterone. So exercise will slow down the aging process, but unfortunately, your body's not going to make more testosterone at age 70 than when you're at 40, okay? Even with how much exercise you have. You might just preserve it. You might just slow down the decline a little bit. The exercise will help with some of the side effect symptoms of the hot flashes and some of the ADT symptoms. So we usually tell guys to get on a pretty intense exercise regimen when you're doing ADT. But the problem is that you don't feel well. You know, when your hormone level is low, you don't want to go to the gym. You know, you're not motivated, you know, but exercise can definitely help you during your ADT period to help you mitigate some of those side effects.
Yes.
Is ITP feasible for a patient who's had brachytherapy, LDR?
Yes, yes. So whether you have surgery, radiation, or on chemo, or on ADT, the penile implant surgery is available to all the guys, okay? The only time we had to choose difference is really for the incontinence, for the urine leakage treatment. Then we had to, then the radiation will preclude you from the sling procedure. You will need the sphincter procedure. But for the erection side of things, you know, it doesn't preclude you.
I was going to call him, but he had a need to go down the hall here. On my buddy Bob, who's on intermittent for 20 years. He goes off his Lutron and lets his PSA rise and goes back on it and goes down, and he just been doing this for 20 years. He has his energy and enthusiasm, and this is another area that doesn't talk about intermittent in Southern California. Up in LA, they do.
Yeah, so I mean, I think it's changing. The attitude of how people take care of cancer, you know, is changing. Some people are what we call early adapters. They take on these new treatment protocols very early on with maybe less research. And some people are more conservative. They want to do the old school things until they want somebody else to. It's like, are you the guy going to buy the first model of the first new model of the car, or are you going to wait till a couple of years into it, then work out the kinks? You know, I would say LA is probably the people that's going to get the new car on day one, and then San Diego or Southern California, maybe people that we want to see them kind of see what they're like first before we get the year 2 or year 3 model. You know, so I think the medicine's no different. You know, some people, like, you know, at the university, we're a little bit more pushing the envelope, a little bit more maybe cutting edge, and some people might be say, well, let's let Dr. Mike do the crazy stuff first, and then we'll follow him if it works out, you know? So, but that's more personal preference and attitude.
Yeah,
One question back there, sir.
So how do you approach the intermittent then with the testosterone? So if you did, say, 6 months or a year of ADT, would you immediately go with the testosterone for a year?
No, so most people on intermittent ADT, they don't have a testosterone, or their body can usually regenerate testosterone because they're only on it for a couple of months at a time, and then they live off their own hormones. So most of those men are not on testosterone replacement therapy. They're just on less ADT than the standard treatment protocol. So maybe 3 months a year, they'll have low T, and then another 4 or 5 months, they'll have normal T, living off their own hormone. And then once your PSA is not behaving anymore, they put them on ADT again for a period of time. So this is up and down things. So your body, they're always making a little bit on the background.
All right, 2 more questions, yes.
What's the normal testosterone number? Is it vary or?
So that's a good question. The question is about what's normal testosterone number. The short answer is I don't know, okay? When you get a lab test, the lab is going to tell you normal is between 300 to 800. Why is this so why? Because we have no idea, okay? We do know what low is. When you fall below 300 or 250, you're not going to feel good, okay? But people always ask me, well, what should my number be? And unfortunately, I don't know, okay? If I draw a vial of blood in everybody in this room, women included, and I check your testosterone, biochemically, our hormones are all the same. But that same vial of blood, if I sequence your androgen receptor, we're all different. We all have different sensitivity, a different need for testosterone. You might see a guy, 90-year-old guy who's doing triathlons, and you're like, how does he do that? You know, his testosterone level must be really low because he's 90. But he doesn't need a lot of testosterone for your body to work. But in somebody else, I might see a man who's 35 years old who's having a hard time conceiving. Their testosterone level is 400, and he doesn't feel good, okay? So unfortunately, and I do research in androgen receptor at UCSD, but that's really more of a research thing than, I hope one day, when I check your testosterone level, not only I know it's high or low, I can also, based on your need, tell you what your normal is. But unfortunately, today, it's more of a trial and error. So your hormone's low, we put you on testosterone, and then we check your level again, and we check in with you. If you tell me that I feel great, and your blood test says 600, that's your number. Okay, so we're in a trial and error phase of testosterone, but one day, hopefully, we won't do that.
Yeah, blood pressure medication could be a cause of ED and also incontinence.
So the questions about blood pressure medicine, would it cause ED or incontinence? As I mentioned before, medications can give you side effects. Blood pressure medicine that lowers your blood pressure can also lower blood flow to your penis. So it's not uncommon. People say I was doing fine until I had a heart attack and my doctor put me on all these blood pressure pills and now I can't get an erection anymore. So those are the lowering blood pressure medicines. But if you have heart problems, doctors put you on something called Lasix or diuretics to help you pee a lot, get rid of the fluids that you can get rid of. That can worsen your incontinence because now you're going to the bathroom all the time instead of every 2 or 3 hours. So you're right, some medicine can affect your sexual function. Some medicine can affect your urination. That's why when we see the patients, we look at your medication list and we go over them with you. Well, I'm not going to take you off your heart medicine or your Lasix, but we will go over how to help you manage that.
Okay, that was the last question. Thank you very much.